Technical Refresher for Radiography of the Hip. This module was written by Susie Mosley, B.S., RTR, and Megan Lemp, B.A., B.A. After completing this module, you will be able to describe the patient preparation requirements for radiography of the hip, explain how to position a patient for a hip examination, summarize the technical settings and patient instructions necessary to produce a diagnostic image, identify major structures seen on hip radiographs, list the evaluation criteria used to determine image quality. The hip is generally examined using unilateral AP and lateral projections, although an AP projection of the entire pelvis and proximal femora is sometimes performed in the initial evaluation of a hip lesion. Standard positioning for hip examinations involves manipulation of the lower limb, which may be contraindicated in patients who have traumatic injuries or certain pathologic conditions. Clear communication with a patient will ensure that a proper patient history is acquired and that the patient will comply with all instructions. It is generally good practice to explain the procedure to the patient before exam positioning so that any questions can be answered immediately. When examining the pelvis and hip, it is especially important to advise the patient of the palpation methods that will be used to localize anatomic structures before positioning begins. Patient history includes a discussion of any known anatomical variants that may affect the exam, as well as any medical devices implanted in the area of interest. For example, technical factors will need to be adjusted if a patient has a joint replacement or severe arthritis. Patients must remove clothing and jewelry in the area of interest and be provided with a gown for privacy and to prevent the patient from getting cold. The AP projection for a unilateral hip examination is performed with the patient positioned supine on the radiographic table and the leg extended. Have the patient place their arms in a comfortable position outside of the field of view. To ensure the pelvis is not rotated, adjust the patient's position so that the anterior superior iliac spines, or ASISs, are equidistant to the radiographic table. Unless contraindicated, the patient rotates the affected leg and foot approximately 15 to 20 degrees medially to position the femoral neck parallel with the plane of the image receptor. If needed, place a cushion under the knee and a sandbag over the ankle to help the patient maintain the correct position. The central ray should be directed perpendicularly to the femoral neck, which is located approximately 2.5 inches or 6.3 centimeters distal on a line drawn at right angles to the midpoint of a line between the ASIS and the superior margin of the pubic symphysis. The image receptor should be centered to the central ray. If a patient has an implanted orthopedic device, adjust the image receptor size and central ray position to include the device in its entirety. Anatomical markers are placed on the image receptor to identify the anatomical side that is being examined. The patient's gonads are shielded, and the shield is placed between the X-ray source and the patient. The patient should be instructed to hold very still, and the exposure is made on a suspended breath. A 10 by 12 inch or 24 by 30 centimeter image receptor is used for an AP projection of the hip and is adjusted lengthwise. The SID should be set at a minimum of 40 inches, although some departments may require a longer SID. 85 kVp is a common setting for an AP hip projection performed with a grid. Automatic exposure control is commonly used to select the proper mass setting for hip radiography. However, common mass settings are 20 mass when using computed radiography and 10 mass when using digital radiography. A large focal spot is selected. The AP projection shows the femoral head, femoral neck, greater trochanter, lesser trochanter, and approximately 1/3 of the proximal femoral body. Portions of the ilium, ischium, and pubis are also seen. The following quality criteria are used to determine if an AP hip radiograph has been produced with proper positioning and technical factors. Collimation and gonadal shielding do not obscure relevant anatomy. Portions of the ilium and pubic bones adjoining the pubic symphysis are visible, along with the hip joint and proximal 1/3 of the femur. The femoral head is visible through the acetabulum. The long axis of the femoral neck is demonstrated without foreshortening, and the greater trochanter is seen in profile. Most or all of the lesser trochanter is not visible beyond the medial border of the femur. Orthopedic devices, when present, are visible in their entirety, and soft tissue and bony trabecular detail is well displayed. A lateral hip projection, using the Lowenstein and Hickey methods, is not used for patients who have a suspected fracture or pathologic condition. In these instances, an axiolateral or modified axiolateral projection is performed instead. Positioning for the lateral projection of a unilateral hip examination begins with the patient lying supine on the radiographic table. The patient places their arms in a comfortable position outside of the field of view. Have the patient rotate slightly toward the affected side and flex the affected hip and knee, abducting the leg until the thigh is nearly perpendicular with the hip bone and the femur is parallel with the table. The patient's pelvis may be rotated slightly to accommodate this position, but the affected hip should remain free of superimposition. The hip is centered to the midline of the image receptor. The patient's opposite leg is extended, and a cushion may be placed underneath the contralateral hip and knee for support. In the Lowenstein method, the central ray is directed perpendicularly to the hip joint, which is located at the midpoint of a line drawn from the ASIS to the superior margin of the pubic symphysis. In the Hickey method, the central ray is angled 20 to 25 degrees cephalic and enters 1 inch or 2.5 centimeters inferior to the hip joint. The image receptor is centered to the central ray. Anatomical markers are placed on the image receptor to identify the anatomical side that is being examined. The patient's gonads are shielded, and the shield is placed between the X-ray source and the patient. The patient should be instructed to hold very still, and the exposure is made on a suspended respiration. A 10 by 12 inch or 24 by 30 centimeter image receptor is used for a lateral projection of the hip and is adjusted crosswise. The SID should be set at a minimum of 40 inches, although some departments may require a longer SID. 85 kVp is a common setting for a lateral hip projection performed with a grid. Automatic exposure control is commonly used to select the proper mass setting for hip radiography. However, common mass settings are 18 mass when using computed radiography and 9 mass when using digital radiography. A large focal spot is selected. The lateral projection shows the proximal femur and demonstrates the relationship of the femoral head to the acetabulum. The greater trochanter superimposes the femoral neck when the Lowenstein method is used, whereas the Hickey method demonstrates the femoral neck without superimposition. The following quality criteria should be used to determine if a lateral hip radiograph has been produced with proper positioning and technical factors. The collimation and gonadal shielding do not obscure relevant anatomy, and the hip joint is in the center of the image. The hip joint, acetabulum, and femoral head are all visible. The greater trochanter superimposes the femoral neck when a perpendicular central ray is used, and the femoral neck is seen without superimposition when the central ray is angled cephalic. Soft tissue and bony trabecular detail are clearly visible. This concludes the clinical refresher for radiography of the hip.